Okay, so I was asked by Manos to speak about innovation in antiplatelets. So what I'll say is, to summarize a little bit, there aren't new medications that are going to be coming out anytime soon, and there's, we're all pretty familiar with the armamentarium that's available to us. And many of these agents have been studied for a very long time. I think the innovation is coming in how we apply these therapies. What is the duration of therapy? What population do we apply them in? Are we simplifying some of the regimens by eliminating unnecessary medications? And what I'll say is it's extremely difficult in our field to remove things. So we like to add on things. We would like to add on a low-dose antithrombin after an acute coronary syndrome, but what do we do about the aspirin? So I think that's what we're trying to unlock now. Here's a very busy slide, but just looks at the number of trials that have been done looking at antiplatelet therapy over the last kind of 22 plus, 23 plus years, and they've culminated in, I think, a lot of confusion, for me at least. But here's the DAP duration kind of overall guidelines for an acute coronary syndrome. 12 months. Shorter can be considered if the person's at high bleeding risk. And for stable disease, we want to do at least a month. And for secondary prevention, prior MIs, maybe stroke, peripheral arterial disease. But I think, just this slide illustrates the difficulty that we have in recommending duration of DAPT as interventionalists, but also recommending to our non-invasive colleagues, what was the clinical syndrome that we're treating? When are we talking about secondary prevention of events unrelated to the stent? And when are we talking about things related to the stent? And so I think that's what we need to codify in our minds. Are we talking about an acute coronary syndrome patient? Are we talking about high-risk anatomy? Are we talking about somebody who's at high bleeding risk? And are we talking about somebody where the reason we're giving dual antiplatelet therapy is to prevent a recurrent event versus stent thrombosis? Just to talk about things that have transpired in the last year or so, the Augustus trial was announced, and now we're into another area where we've had significant confusion of what to do, and that is in the AFib patient who's undergoing PCI and now has a stent. In this case, this was apixaban compared with warfarin. The first hypothesis was apixaban was that non-inferior to warfarin, and then the patients were randomized to aspirin or placebo after that. So in other words, triple therapy or dual therapy. And as you can imagine, as was the case in the AFib trials in the first place, there's some advantage to the newer agents with regard to both bleeding and in some cases the ischemic events. But in general, we think advantage over warfarin and maybe a greater amount of time in therapeutic range compared with warfarin. What about bleeding? Aspirin versus no aspirin. So we're saying on top of the baseline therapy with the P2Y12 inhibitor and an anticoagulant, the aspirin increases the risk of bleeding. So you see, if you look at all four of the possibilities, the lowest risk is amongst those patients receiving apixaban and the P2Y12 inhibitor, or warfarin and the P2Y12 inhibitor. The triple therapy arms have increased risk of bleeding. Reduced chances of mortality or repeat hospitalization for apixaban versus warfarin. Aspirin versus placebo, not so much of a difference. Overall, these are the number needed to treat of about 18 for apixaban plus placebo versus triple therapy with a warfarin. Ischemic outcomes, not substantively different, but you see an advantage with apixaban with regard to reduction in stroke. The reason why that's important is very frequently you will hear from the electrophysiologists that maybe this is an inadequate treatment for atrial fibrillation, and maybe we need to be more aggressive, particularly when we're talking about lower doses of rivaroxaban. And this is where I think it's important. There are two kind of comments that I make to my colleagues is that I'm not subject to the tyranny of the CHADs. that just because we calculated a score of what the stroke rate is at a year doesn't mean that that's the immediate threat to the patient in the short term. In fact, the immediate threat to the patient in the short term after they've had a stent is recurrent MI and stent thrombosis. And then if we put them on triple therapy, we've given them an additional threat, which is bleeding. We can divide the risk of stroke in a linear fashion across the year, but these patients do derive some benefit from maybe bumping up their antithrombin therapy to something that may be more effective and also avoiding the risk of aspirin. So now moving on to the chances that we can improve things by reducing the types of medications that we give after the PCI. The Global Leaders study looked at, in this case, the Biolemus stent, looking at 1 month of aspirin plus ticagrelor, and then followed up the following 23 months in a 2-year follow-up with monotherapy with ticagrelor versus 12 months of dual antiplatelet therapy. Acute coronary syndrome patients got aspirin ticagrelor, elective patients got aspirin and clopidogrel. And then 12 months of monotherapy with aspirin, so discontinuing the P2Y12 inhibitor after a year. The primary endpoint was to see if there was superiority versus the reference treatment, and in this case, there was not. There was not actually an advantage to removing the aspirin and going with ticagrelor monotherapy. So the conclusion of this trial was not to abandon current strategies that involve dual antiplatelet therapy. So the SMART Choice study looked at people undergoing successful PCI, excluded patients with complex anatomy or hemodynamic instability, and looked at 3 months of DAPT followed by just the P2Y12 inhibitor versus standard therapy out to a year. And again, not substantive differences as far as ischemic outcomes, but differences related to bleeding by reducing the exposure to aspirin. STOP-DAPT2 also reported this year, looking at patients with 1 month of DAPT versus 12 months of DAPT. The continuation was with clopidogrel in this case, and the primary endpoint was net clinical benefit, and these are the individual endpoints showing that there was an advantage again with bleeding. So I think looking in totality at these types of procedures is if we can reduce the aspirin exposure when we think that the patient is through the largest or greatest risk for recurrent events, that may be beneficial. But in an overall population, this has not been shown to be beneficial yet in the Global Leaders studies. But selected patients, the high bleeding risk patients, this is maybe something to consider. This study looked prospectively at acute coronary syndrome patients. A variety of different stents were used. The dual antiplatelet therapy group for 6 months versus 12 months. This was a SMART DATE study and reported at ACC this year, late-breaking clinical trial, and there was no advantage in the primary endpoint of MACE. And there was a signal, actually, that when discontinuing the dual antiplatelet therapy in this acute coronary syndrome population, that there was increased events. So again, probably not the population that we want to scrimp on the dual antiplatelet therapy, especially if they're not high bleeding risk types of patients. The DAPT STEMI study run by Dr. Katie in the Netherlands looked at all patients on DAPT for the first 6 months and then continued DAPT for 12 months in one group and then single antiplatelet therapy for the next 12 months. And they were randomized against single antiplatelet therapy for 18 months. And in this case, there was a numerical reduction in the primary endpoint of death, MI, revascularization, ischemic events, and major bleeding, but no statistically significant difference in the reduced strategy. So again, we don't or maybe shouldn't change our strategy for the STEMI patients. And then just to highlight ongoing studies that may shed some light on overall population, Evolve Short DAPT study is looking at the Boston Scientific stent, looking at P2Y12 dual antiplatelet therapy followed by aspirin alone, and looking at ischemic endpoints and major bleeding ongoing, but has completed enrollment. Twilight study being run with Roxana and Usman, looking at single antiplatelet therapy after 3 months with ticagrelor versus ticagrelor and aspirin, and looking at ischemic and combined bleeding endpoints. So looking forward to reports on the other short DAPT studies, Science 90, Science 28 commencing, Onyx 1 also almost completing enrollment. So in summary, the innovations in antiplatelet therapy are not new medications, but rather we're going to be doing things by tailoring the therapies to our patient populations and anatomies with the understanding of these trials so that we can do things better, do things safer, treat our patients more efficiently. And we're going to have to question long-held paradigms like aspirin is the focal point of antiplatelet therapy, and we add on top of that. And these are going to benefit patients in the healthcare system, not only with outcomes, but readmissions and reductions in cost. So thank you very much, and I'll move on to the panel for any questions.